Hello and welcome. This is episode 2 of USMMA EMS Training Online. I'm MIDN Alcorn, the ResTow. Today we'll be going over the Crew Chief Certification Training. The purpose of this training is to give you all the skills you need to become a crew chief. So I'll go over all the information, all the protocols that you will need to pass the test. Test you need 70% or higher. And all the information will be in this PowerPoint or the online training before. And you'll be endorsed by the CO, XO, and myself. These are the topics we'll discuss. And here are the calls, transports, and possible RMA for you to require to be a crew chief. It's the course content and the watch team. Starting with the tip of the spear, we have the driver and the rider, down to the crew chief who delegates the tasks, charges the patient care, supervisor, and EMS officers. Just standing behind the lines, delegating, seeing what's going on. This is a review. A note that the CO added was that this is the very narrow section here. This is where cars are parked on both sides of the street, and you really have to be wary. We have clipped the ambulance once and come very close on multiple occasions. So drive slow and use due diligence when going through that area. And the driver, also make sure the driver brings the equipment from the bus to the scene. The oxygen bag and the trauma bag are very important for the care for the patient. And they're a lot more organized than the big rucksacks that we currently carry around. And bus placement, if the bus is taken all the way to the waterfront or around a back company path or somewhere where it's hard to get the bus in and out, the driver's responsibility to find a good entrance into the area and find a good exfil route. So keep that in mind when you're driving. This is review. An area that I would like to annotate is that we are going to walk. We are not going to run to the call. Running makes you seem frantic or you're not in control of the situation. So be professional and walk to the call. You can walk briskly, but do not run. And then I'll go in details about assuming command. Scene safety, make sure everyone has their BSI. And assuming command. So let's say the crew chief is not the first person on scene. Well, what do? Get the story from whoever shows up first, be that the technician or the OIC. So ask them so that it's a seamless transition from whoever shows up on scene to the crew chief. Crew chief is in charge of patient care. They're the person that goes in the in-charge slot on the PCR. So making sure that crew chief knows what's going on is imperative for the responsibility that they have. And be confident. Confidence is shown in not just the words you say, but in your actions. So if you're kind of shaky and you're bugging out a little bit, your eyes are wandering or looking around, you're pacing back and forth, and you really don't know what to say, patient sees that. And if you just take a deep breath, rely on your protocols, and fall back in your training, I think you're going to be all right. Patient care. Just a note that I highlighted and underlined is take appropriate interventions. How do you know when you're taking appropriate interventions? Well, the protocols outline what are the best practices from studies, and based on protocols, they look at what the best practice is for a patient. So if you don't know what the best intervention is, fall back in your protocols. This is review. So let's say you're a crew chief and you start to whiz out and you don't really know what to do. Call on the radio. OIC to scene. The OIC will come. They're always ready to respond. The OIC is there for help. So if you need help, they'll be there. But before they get there, just fall back on your training. Go over your AVPU. Alert and oriented. What is the general impression of the patient? Go over ABCD. Airway. Is their airway patent? Are they able to speak? Do you need to put an airway adjunct in? Breathing. Are they having difficulty breathing? Wheezing? Any strange sounds in their breathing? Auscultate. Look, listen, feel. For the circulation, are they bleeding anywhere? Can you control the hemorrhaging? Skin condition. Color, temperature, condition. Cool, pale, diaphoretic. What does that mean? Shock. So treat accordingly. And then D, your decision to transport. So they load and go, RMA, stay and play. What's your call, crew chief? The refusal of medical assistance or assessment. Now, the last slide was incorrect. That was from the last protocols. Not much has changed. The only thing has changed is non-ambulatory can RMA. So this is a list straight from the protocols. Follow this to the T. These are people who cannot RMA. Altered mental status, less than 18 years of age, dangerous to themselves or others, irrational manner they are acting in, unable to verbalize an understanding of illness, unable to verbalize rational reasons for refusing care, or no legal guardian. Document these causes and what they're RMAing for or what they're not able to RMA for, and take the patient to the hospital. If a patient is able to RMA, you must note these to the patient. So let them know, make sure they understand the consequences of refusing transport. Offer them transport. Explain the risks of not getting transported. Explain the possibilities of getting injured due to refusing transport. Advise them to seek medical attention. Make sure the patient understands what you're saying. Lead the patient to a responsible adult and advise them to call again if they decide they need to go to the hospital for real. Make sure the nurse, physician, ALS provider, or patient RMAs. So these are your signatures. When are you relieved? Now this is heavy in the training. This is the protocols for administering interventions or drugs. BLS medications. This includes epinephrine, nitroglycerin, aspirin, albuterol, Narcan or naloxone, oral glucose, and oxygen. But before we mess with the body, we got to know what the patient is like, what the patient's physiology is before we give any of this medication. So we get a baseline vitals, we get a general impression, and then you can start messing with their physiology if you know that they're the right condition to give these drugs for. And also, before you give any medications, ensure the 5 rights: right patient, right medication, right dose, right route, and right effect. Are you helping this patient by giving this drug? And always check the expiration date. For epinephrine, notice that it is extended a year. I'll address this in the email to make sure everyone knows, but if it is a year from within their expiration, we are still able to use epinephrine. And I'll go into detail, but call medical control when you're required to do so. First one, epinephrine. Criteria 1, rapidly progressing, life-threatening allergic reaction, also known as anaphylaxis. This is not simply a rash or hives. This is severe respiratory distress, facial or oral edema, which is swelling of the face or neck, and or hypoperfusion. So this patient is having an allergic reaction and they're feeling their throat and mouth are closing and they're unable to swallow or breathe. And or hypoperfusion, hypo meaning low, perfusion meaning blood flow throughout the body. So let's say they have this allergen, histamines are released in the body, which causes vasodilation. Vasodilation can cause anaphylactic shock. So the patient is going into shock due to this anaphylaxis. What we're going to do is we're going to take our EpiPen auto injectors and we're going to administer 1 dose into the lateral mid-thigh. So you're going to expose the thigh and inject it perpendicular to the thigh, right in, just straight in, and hold it for about 10 seconds. Let the meter dose administer fully. And always use the patient's injector if available. Another note, if the patient does not improve in 5 minutes, you may repeat once. So that's 1, wait 5 minutes, give another dose if they haven't received any relief of their oral edema or their respiratory distress. and notice the peds, notice the weight and restrictions for a ped epinephrine pen. The second condition. So this is a patient with a history of anaphylaxis. The condition 1 had no history of anaphylaxis. This is simply they're going into allergic reaction. For example, a person who's never had allergic reaction before and is going into anaphylactic shock, or just having an anaphylactic reaction. Condition 2 is the history of anaphylaxis. So a person who has a nut allergy, allergy to shellfish, they know this already and they know what's going on. So they have an exposure to this allergen and they're developing respiratory distress and or hyperperfusion and or rash. So the big things are hyperperfusion and respiratory distress. These are the big two that you're going to look for with this history of anaphylaxis. And this is to address also anaphylaxis, is if a patient is wheezing, you can give albuterol. You may repeat up to 3 doses and consult MedCom if you need to do any more than 2 epinephrine doses and 3 albuterol doses for a patient going into anaphylaxis with respiratory distress and or hyperperfusion. The second drug is nitroglycerin. This is a patient with suspected cardiac chest pain, angina, or anginal equivalent. What is angina? Angina is action-induced chest pain. So angina, action. This is from a patient who gets up to walk and their chest starts to hurt. They're mowing the lawn and their chest starts to hurt. Anginal equivalent is referred pain. So the heart maybe has never felt pain before. The cells have never fired in that way. So the patient will feel it in, let's say, their left shoulder. The left shoulder will hurt or their jaw will hurt. So this is referred pain, means pain in other places other than the origin of the receptors. So nitroglycerin. If a patient requests, assist with their prescribed nitroglycerin. So we do not hold nitroglycerin. Patients are prescribed this and you assist. Up to 3 doses, 5 minutes apart, provided that the BP is over 120. Systolic. So just a little way that I remember systolic over diastolic. Systolic, sky over dirt. Systolic, diastolic. If it helps one person, then I'm happy. Administration guidelines. Question patient about last dose and effects. Did it help? What did you do? How many doses did you give yourself? And assist administering the prescribed dose. Record time of administration. This drug is given sublingually, so it's under the tongue. In the example I gave here, this is the spray, so you spray the meter dose under the tongue, right where all those nice capillaries are. And the other one is the tablet form. Excuse me. The tablets are placed under the tongue and it's left there sublingually. Sub meaning below, lingual meaning the tongue. This drug is a vasodilator, so it opens up the blood vessels. This is why a patient has to have a blood pressure of above 120. Because if you give a patient nitroglycerin while they're hypotensive, you could put them into more shock and possibly kill them. So keep that in mind. MedCom considerations. Additional nitroglycerin, 0.4 milligrams every 5 minutes for an EMT. So consider MedCom if you want to give more than 3 doses. If a patient becomes hypotensive after nitroglycerin administration, place the patient in the supine or face-up position, lying down. There's no contraindications besides pulmonary edema. Pulmonary edema is fluid in the lungs. The reason why you don't want to put them in the supine position is because when they're in the supine position, blood flows to the lungs. And with the edema or fluid in the lungs already, it puts great pressure on the lungs and makes it harder for them to breathe. So you'll set this patient up or just put them in a position of comfort. Aspirin, ASA, or acetyl salicylic acid. Try saying that 5 times fast. So the criteria for this, patient presenting with suspected cardiac chest pain, similar to nitroglycerin, angina or anginal equivalent. They're administered chewable tablets, as you can see in the top right corner. They're these small little tablets. You'll give them 4 81 milligram tablets, or 324 milligrams total. Chew them. The only contraindication for this first part is that they're able to chew. So if they're unable to chew or unable to swallow, you can't give them acetylsalicylic acid. Contraindications for the drug itself is that they've already taken it. They're allergic to aspirin. They have a history of GI bleeds or current head trauma. The reason for this bleeding relationship is that the aspirin is an anticoagulant. Anticoagulant means that it inhibits the platelets from sticking to the blood or clotting. So basically makes their body hemophilic and will make someone bleed more and more and more. So if they have current head trauma or possible brain injury, or they're bleeding internally, do not give them aspirin. This is a big deal. If any concerns about the patient having received an effective dose prior to your arrival, you may give an additional 324 milligrams. So this is for you to say, I don't know if you gave it, or they said they took it and you're not sure. Give them the 324 milligrams. This takes weight off your back. Albuterol. So albuterol comes in these nice little packets here, and it's this plastic vial here. So albuterol sulfate is given for patients with effective but increased work of breathing with wheezing. So it's with wheezing, that's the big thing. Administration guidelines is one of these vials via O2 nebulized at 6 to 8 liters per minute, up to 3 doses if symptoms persist. Contraindications, they have a history of angina, to action-induced chest pain, MI, myocardial infarction, or a heart attack. Arrhythmia, this is imbalance in the heartbeat, imbalance of the left and right chamber. CHF, congested heart failure. This is when the chambers of the heart are swollen or congested, and it makes it inefficient of pumping. For these contraindications, MedCom must be contacted prior to administration of albuterol. Albuterol precaution. This is for current COVID-19 situation. Because albuterol makes a vapor, the patient's exhale will be vaporized and be all throughout the bus and your environment. So for this instance, you're going to don PPE, proper PPE, an N95 respirator, which we will get fit tested for soon, eye protection or goggles, gloves, and a gown prior to any procedure with the patient in dealing with aerosol drugs. This is regarding patients who are positive or not, if they have symptoms or any diagnosis. I don't care if they have COVID or not. We're going to do this. We're going to don all this PPE. All patients requiring nebulized medication should use a delivery method that limits misting into the environment. If unavailable, use the metered dose inhaler that the patient should have. Narcan. This is the big opioid drug, lifesaver. So the criteria for this, only administer naloxone or Narcan to patients with suspected opioid overdose with hypoventilation. Hypo meaning under, ventilation meaning breathing. So they have low, shallow breaths or ineffective respirations. They're breathing so slow and so shallow that they're not getting enough oxygen throughout their body. They have a lot of respiratory depression or depressed respirations. For provider and patient safety, do not administer without medical control order if they have adequate ventilation. So if they're breathing normally and they have an opioid overdose, contact MedCom, see if you can still give a Narcan administration. Look for the pinpoint pupils. Just take a look at the eyes, shine a light, see if they're still pinpoint. Check the blood glucose level if equipped. We're not equipped, but we're working on it. Administration guidelines. Administer naloxone, Narcan, 2 milligrams. So you're given the, pardon me while I check, mucosal atomizer device. I had to look that one up. So that's the tube that I'll show you next slide. So you're given 2 milligrams in this vial. You'll push through one in one nostril and give the other in the other. So may repeat once in 5 minutes. So that's once, 5 minutes later, do another dose. So these are examples of opioids. These are the painkillers you'll encounter. These painkillers in an overdose cause respiratory depression. Contraindications, like I said, are adequate ventilation, so you must contact MedCom. And these are the dose. You're going to take off this cap here, this cap, screw on, and it's already inserted. And then just push that vial in halfway in the first nostril and second in the other. So a note here is you may substitute alternate FDA and CMAC approved commercially prepared 4 milligram nasal spray unit dose device. So these are the dose devices you'll get from Walgreens, CVS, and you can use those. Oral glucose. Oral glucose comes in this nice little toothpaste tube filled with sugar paste. So the criteria for this is hypoglycemic patient or altered mental status, AMS. So that's a big thing. They have the low blood sugar and they are also altered mental status. Patient is conscious and able to swallow without risk of aspiration. So you can't give it if they're unable to swallow. That's a big thing too. Whenever we get equipped with the glucometer, you'll check and it will be less than 60. This is the criteria you need to give the glucose. Administration guidelines. You'll use the entire tube of paste. Usually there is a tongue depressor that you can use to administer, or you can just use your fingers and swab inside the cheeks. You'll use the entire tube orally or substitute it with a fruit juice or non-diet soda. This is your high sugar drinks, cranberry juice, apple juice, or any Coke, Pepsi, non-diet sodas. Again, I say contraindications, patient is unconscious and unable to swallow. Do not give them anything orally or they will aspirate. Oxygen. Criteria for this is that given to maintain oxygen saturation if less than 94. We have the SpO2 monitors, and you can check that. Less than 94, give oxygen. Or the other criteria is to effectively manage other signs of dyspnea. Dys meaning difficult, pnea meaning breathing. So difficulty breathing. You're no longer just going to give oxygen to every patient that talks, walks, and wants to go to the hospital. So the nasal cannula, example here, given at 2 to 6 liters per minute. Non-rebreather, shown here, given 10 to 15 liters per minute. We have the bag valve mask here. Hook up oxygen and give at 15 to 25 liters per minute. The bag valve mask is given to patients who cannot maintain their own airway. And consider using airway adjuncts like OPA and NPA. OPA given to patients who do not have a gag reflex. NPA given nasally for patients who do have a gag reflex. Remember, contraindications for OPA and NPA are patients with facial trauma. So if they have trauma to the jaw or nose, you can't give either. After administering, recheck vital signs. Make sure, follow up with your patient. Did they get better? What's their condition? And if you contacted MedCom, write that time on the PCR. Types of transports, this is a review for the most part. Only transport midshipmen. Use discretion when lights and sirens. Call in your signals. Here. I'll go over the PCR training later, so stand by for that. But just a thing that I'd like to mention is that even if you don't find a patient, you do a PCR, and we'll also do PCRs for standby. HIPAA, don't give out your patient information. Make sure there's not too many people on the scene. Be respectful to commissioned officers. after the call. So this is a slide that I'd like to mention. I'm not saying that every protocol I just mentioned is null and void now. This is one of the first pages, and it addresses the situations that we can't account for. These protocols are intended to guide and direct patient care. These protocols are not intended to be absolute treatment documents. No protocol can be written to cover every situation. Best clinical judgment and deliver care should be made. Use reason and be prudent in specific situations. Any deviance from the protocols shall be documented and reviewed. And the last statement, this big, bold statement, these protocols are not a substitute for good clinical judgment. So that gut feeling you have, listen to it. Whatever situation, I can't tell you whatever situation you'll be in, but use your good clinical judgment. And my favorite, the hot wash. Crew chief, as the leader of the pack, they're going to review the call, what went wrong, what went good, what went bad, what can we learn from it, and let the OIC know if any of your situations spark some future training we can do. For the officers, if you got something to say, let the crew chief and rest of the team know it, and let's all get after it. Ask for help. Listen to midshipman officers here, DPS, MedCom, great resource. Poison control if you ever get in that situation, ALS, and vigilant. And for the next slide, I have all the numbers. The first three are, and all the starred ones are the ones that I want all of you to have in your phones. Sager, Senate, Klein, Great Neck Vigilant Dispatch, non-emergency business line for Great Neck, and MedCom. So the three big chiefs we have, Sager, Senate, Klein. These are good for any questions you have about the squad, and they're also great resources in sexual assault. So if you ever get in that horrific situation, call them. EMS dispatch, everyone should have that number. Not emergencies for your radio signals and general questions, and MedCom for all your MedCom considerations for protocols. That's all I have for you guys. I hope you enjoyed the training and hope you do well in the test. For the protocols, if you have any questions, or email one of the officers. Thank you very much. Bye-bye.